Bueno, pues empezamos, amigos, las dos conferencias inaugurales. Y en primer lugar tenemos la participación, la ponencia del doctor RAPHAEL LANDOVITZ. El doctor LANDOVITZ es profesor asociado de Medicina de la Universidad de California en Los Ángeles y es una de las autoridades mundiales en el momento actual en prevención médica de la infección por VIH. Ha tenido la gentileza de venir desde California a compartir con nosotros todos sus conocimientos y se lo agradecemos mucho. Y Rafael.
Buenas tardes. That's all of my Spanish, I'm sorry. It's a tremendous honor and a privilege to be invited here by the conference organizers with such esteemed colleagues. So thank you for inviting me to share some thoughts with you about pre-exposure prophylaxis for HIV infection, what we know and what we still don't know. Some statistics about which you are all too aware is there were 2 million new HIV infections in 2014 that equivalent is approximately 5,600 new infections per day. We have just heard some recent epidemiology in Spain that there are still 3,000 new infections every year, 1,000 in Madrid. And all this despite a broad array of prevention technologies that we have at our disposal. Today, I'm going to focus most of my comments on oral pre-exposure prophylaxis, or PrEP. I'm going to start by defining what is PrEP, where PrEP came from, talk about the early effectiveness trials and some modeling that comes out of those trials, some considerations that we've struggled with in the US about how to implement PrEP across at-risk populations, what we've done so far in terms of scale-up and implementation, and what the barriers to those implementation activities are, and then looking forward to the future of biomedical prevention with PrEP and other technologies. So PrEP stands for pre-exposure prophylaxis. It's a strategy of administering antiretroviral therapy to someone who is uninfected but at risk for becoming HIV infected. Two good analogies are the use of malaria prophylaxis when someone travels to a malaria endemic area, or the use of a birth control pill to prevent pregnancy in women who are sexually active without condoms but don't wish to become pregnant. In the US, the only FDA-approved medication for PrEP is a fixed-dose combination tablet of tenofovir and emtricitabine. That's tenofovir disoproxil fumarate, which is available through Gilead Sciences as a fixed-dose combination as Truvada. It's also available as generic in some countries. It's safe and well-tolerated, has good pharmacokinetics, and we have a lot of experience with it from treating HIV-infected populations. Also, in non-human primate models, mostly macaque monkeys, there's extremely good data that the strategy of challenging these macaque monkeys after being exposed to the components of tenofovir and emtricitabine is highly protective against rectal, vaginal, and intravenous exposures. You're all very familiar with the mechanism of action of tenofovir and emtricitabine to fight HIV. It's a nucleoside or nucleotide reverse transcriptase inhibitor. That's not a surprise to anyone. But Jose Castillo-Mencía presented some very interesting data in the last year that actually suggests that perhaps it induces immune quiescence, that there is decreased activation of DR-CD38 positive lymphocytes, as well as reductions in certain cytokines after 30 days of administration of Truvada in HIV uninfected patients, and then observed for an additional 30 days, which is a provocative additional mechanism through which tenofovir emtricitabine might actually be protective against HIV infection. But why would you give HIV medications to an uninfected individual on any sort of regular basis? Many people thought that was madness. And I have to admit, when I first heard of this, I did also. It seemed very foolhardy, exposing uninfected people to toxicity, to cost, to the need for monitoring. What would happen to resistance if HIV infection occurred? I thought it would never work. The analogy that people much smarter than me, though, made was the observation from post-exposure prophylaxis. We know for a long time that if someone is exposed in healthcare settings, and probably in other settings also, to HIV-infected blood or body fluids, and then rapidly after that exposure is administered a 28-day course of potent antiretroviral therapy, approximately 80% of HIV infections can be avoided. And we know from animal models of the post-exposure situation that the closer one gets to the time of the exposure with the administration of the drugs, the more effective it is. The longer the time from the exposure to the dosing, the less effective it is. And we don't know exactly when that effectiveness goes away completely, but many guidelines say 72 hours. Some are more conservative, say 36, 48, but I think we all agree that it should be as soon as possible after the exposure. So these very smart people said, well, what would be sooner than the absolute minimum amount of time after the exposure than to have the medication on board before the exposure takes place? And with such a strategy, could more infections be avoided in individuals who are ongoingly at risk? The first efficacy studies began coming out in 2010, and I think the world really changed in late 2010 when the IPREC study was published in the New England Journal of Medicine, much as it is going to be again today as the IPERGAY study is published in the New England Journal of Medicine. We'll talk about that a little bit later. The IPERGAY study took 2,500 HIV-negative men who have sex with other men and transgender women, randomized them to daily oral tenofovir emtricitabine or a placebo. They were all offered condoms, regular HIV/STI testing, and close counseling about adherence and sexual risk reduction. The first result showed 44% protection, and I think we were all disappointed by that initial result when it came out. The next study, chronologically to be published, was a study very similar to the IPREC study, but done in HIV-uninfected women in sub-Saharan Africa, the FEMPREP study. And that study was disappointingly negative, the point estimate of 6% protection. And no one could understand why that would be so different if we were able to show protection in MSM and transgender women, that in cisgender women, we were not able to show protection. The TDF2 study done in Botswana looked at heterosexual men and women, again, looking at tenofovir emtricitabine or placebo in these heterosexual men and women, and there was overall a statistically significant 63% protection across the study, with differential protection for men and women, and the protection in women not achieving statistical significance. So again, a confusing result. Connie Kellum and Jared Beaton's landmark Partners PrEP study in 2013 for the first time showed not only for tenofovir emtricitabine, but for tenofovir by itself, that there were high levels of protective efficacy for both men and women, and for the first time achieving statistical significance for protection of women. This was in specifically serodiscordant heterosexual couples in Kenya and Uganda. Then, of course, the VOICE study. And the VOICE study was supposed to be the confirmatory study that definitively cemented the efficacy of PrEP strategies for women. And we all know that the results of the VOICE study were very disappointing. They were completely negative. There was no protective benefit shown for either daily tenofovir or tenofovir emtricitabine. Of course, a daily daily vaginal gel arm also showed no protective efficacy, and we can talk about that a little bit later. And finally, the PROUD study, which was a pragmatic study that didn't use placebos, but used a delayed strategy of administering tenofovir emtricitabine to MSM in the UK versus delayed strategy, was stopped early with 86% protection for the MSM. We will come to the IPERGAY study in a moment. This is using daily administration of antiretrovirals. As we all know, the IPERGAY study used a slightly different strategy. But how do you reconcile these very different results across these studies? Many providers were confused, and patients, consumers were confused also by these results. And not surprisingly, you have to look a little bit more carefully at the studies to really understand these results. And it really all has to do with adherence. One of the Surgeon Generals in the United States said many years ago, if you do not take a medication, it cannot work. And that's what we have found with PrEP. And that really is not a surprise. When you look at biological evidence of having taken the prescribed medication, it directly correlates with the efficacy seen in studies. But it's not quite so simple, is it? There are biologic differences between men and women. Christine Patterson from the University of North Carolina did some very elegant tissue explant work that shows very clearly that the components of tenofovir and emtricitabine concentrate very differently in rectal tissues as opposed to cervicovaginal tissues, with a 10-fold difference in concentration between those tissues, suggesting one potential reason for the differences seen in the efficacy for women and for men. And perhaps it's not even the right thing to distinguish women and men as individuals, but to say the route of exposure being largely rectal for the men and largely cervicovaginal for women, because of course women can have rectal intercourse as well. So when you take these data and when you do mathematical modeling from directly observed settings and calculations of drug levels, we get an idea of the potential effectiveness of these interventions. In MSM and transgender women, rectal exposures, if someone has drug levels that suggest taking the medication 7 days a week as prescribed, there is a mathematical model that suggests that you can achieve 99% protection, very different from the 44% that we first heard in the IPREX study. In the Partners PrEP study, women who had plasma tenofovir levels that again suggested regular daily dosing had protection levels modeled to be approximately 94%. Again, a very different result than has been seen in any of the clinical trials or the demonstration projects. But this gives us an idea of the potential that we could reach if this were taken as prescribed. Regulatory approvals we're beginning to emerge. In the United States, we have had approval for tenofovir and emtricitabine since 2012. So it's been over 3 years for us, and still we don't have broad uptake. You're all aware that France just received an approval last week, even though there has not yet been an EMEA approval more globally. There have been applications placed in Brazil, in South Africa, in Australia, and in Thailand, and a number of additional countries that have participated in clinical trials but do not yet have applications in place for regulatory approvals. So what is holding back the use, more even than the regulatory approvals? People worry very much, what is the effect of PrEP on risk behavior? Will people stop using condoms entirely if they know that PrEP is highly effective? What is the resistance that happens if people seroconvert despite taking PrEP? How fast does the onset of protection happen? And how quickly after you stop taking the medication does the protection wane? This is actually something that I'm asked incredibly frequently by potential consumers and patients who use PrEP. They want to know when they will be protected. What is the long-term safety of the medication? We have short-term clinical trials, but in broad populations, is this safe to use for many years? Who should be delivering PrEP? Should it be in hospitals? Should it be in STD clinics? Should it be in primary care clinics, OBGYN clinics? Should doctors even be the ones to actually be administering PrEP? In the US, we have a pilot program where pharmacists are deploying PrEP on their own without a doctor's prescription. This is legal in some states in the United States, not everywhere. I know that is very controversial, but it is a public health approach to deploying PrEP. How do we support adherence best? How do you encourage people to stick to the dosing that's required to maintain the protection? And is it possible to take it less than daily? A very important question that many people want to know the answer to. And finally, is something better coming? Are there better medicines for PrEP that we will have soon? And many people have asked this question today, is how do we find the people who are most at risk and make them want this? I'm just wondering, how many people in the audience have a smartphone? Yeah, so the smartphone companies have been very good at making us all need a smartphone. We all have to text and email all the time and surf the web and use Google Translate so you understand what I'm saying. But we have not been good at figuring out how to make people want HIV prevention, how to make people want to protect themselves. And until we can do that, we may never see broad uptake. So risk compensation, the first big issue. This is a little bit of a complicated slide, and I apologize. This is, on the bottom of this slide, is the effectiveness of PrEP that you will see over a wide range of effectiveness. On the y-axis, you have the kind of changes in risk that might occur. Someone might double their number of sex partners. Someone might triple their number of sex partners if they feel protected. This is called risk compensation. These white lines that are up and down are the various effectiveness estimations that the various trials and demonstration projects have seen. This is model data from Ume Abbas from the University of Pittsburgh. You can see at extremely high levels of efficacy, even if people have high changes in their sexual risk behavior, at a population level, you still do good by deploying PrEP. You still have decreases in population level incidence. But if, in fact, the effectiveness is lower, even at the level that was seen in IPREX, you can see that not only do you lose population-level prevention, you actually increase the number of incident HIV infections if people have more partners and more unprotected sex, if they feel protected from PrEP, but really are not. So this is all in the context of imperfect protection. So this is why people are very concerned about changes in risk behavior and condom use. So all of the randomized trials claim that they have not seen any change in risk behavior. In fact, risk behavior has decreased, more condom use, fewer partners. But these are all placebo-controlled trials, so it's not really the right arena to answer that question, because when these studies were done, no one knew for sure that the medication worked, and there was a good chance that they could be receiving placebo. So what happens now that we're using open label situations? What is happening to sexually transmitted infections? What is happening to risk behavior? We'll come back to that, but I will tell you that these open label demonstration projects in the US are seeing 40 to 60% of people taking PrEP being diagnosed with an incident STI in the first year. So I think it is a foregone conclusion that we probably are seeing an increase in risk behavior. Interestingly, there was a hint of this in the Partners PrEP study. Partners PrEP was the study of serodiscordant couples in Kenya and Uganda that Connie Kellum and Jared Beaton performed. And you can see the number of episodes of monthly sex acts with non-primary partners before the study was unblinded. This is during the blinded portion of the study. When the study was unblinded and efficacy was shown, there was a notable change in the trajectory of sexual activity with these non-primary partners. So even before we went to open label situations, there was a suggestion that people were going to, in fact, change their behavior in the context of PrEP efficacy. But is this going to lead to more resistance if people seroconvert? There have been some mathematical models by Sally Blower and others that have had what I call doomsday scenarios, people predicting enormous increases in the rates of resistant virus and a terrible resistant epidemic. There are other mathematical models that suggest really no change at all. And of course, the problem with mathematical modeling is the model results are only as good as the things you put into the model. So a model can suggest answers, but it doesn't really give us answers. What do we know from actual clinical trials? We know that resistance is actually extremely rare. It seems like people either fall into one of two categories. Either they take PrEP sufficiently well that they are protected against HIV acquisition overall, and there is no concern about resistance, or they do not take PrEP sufficiently, they basically don't take it at all, they get infected with HIV, but there is no drug around to select for resistant variants. The rates of HIV resistance that have been seen in these clinical trials are extremely low, 0.06% overall. The majority of these resistant cases happening when people at the very beginning of PrEP use were in the acute phases of primary HIV infection that were not diagnosed, started on PrEP, and then subsequently found to have been infected at the time they started the medication. Of course, all of these clinical studies tested people monthly for HIV infection. I don't think in clinical practice anyone would really believe that monthly HIV testing would be acceptable. So now that the guidelines in the US, WHO, others suggest that people on PrEP could be tested once every 2 or 3 months, there will be a much longer interval where someone could become infected, presumably while not taking PrEP, restart PrEP without having been tested, and then get resistant virus in that context. So we don't know yet what the real rates of resistance that could be generated will be in clinical practice. So this remains an important concern. How quickly do you get protection? This is for rectal exposures only. It's very important to remember that. Peter Anderson from University of Colorado has done some very elegant modeling work using tissue explants and dried blood spots, and has found that protective levels should be in the appropriate tissues between 5 and 7 days after initiating treatment. And once at steady state, protection should last to the level of about 90% for about a week after stopping treatment. It's very important to remember this is not true for vaginal exposures. Some estimates have said it can take as long as 21 days to achieve the levels in vaginal and cervical tissues required for protection, and our modeling is not nearly as sophisticated for cervicovaginal exposures. What about the toxicity and the safety? Well, it seems like it's well tolerated. We have a lot of experience with this medication in HIV-infected people. There does seem to be a startup syndrome where about 20% of people have some sort of gastrointestinal symptoms in the first 2 to 4 weeks, but that doesn't seem to be very rate limiting in people tolerating and persisting with the medication. Kidney irritation. From the HIV-infected literature, again, we know that this is a concern. Tenofovir disoproxil fumarate is nephrotoxic. And we've seen people go into permanent renal failure, require dialysis, who are HIV infected, taking this medication. So of course this is a concern. The rate of of PrEP inducing these sorts of kidney irritation in HIV uninfected patients seems to be low. In the phase 3 clinical studies, it was about 0.2%, and most were able to stop the medication, have the kidney function recover, and then reinitiate it and continue without a problem. For this reason, PrEP is not recommended at this time for people with a creatinine clearance under 60. So we do not have options today for people with compromised renal function. But bone safety is a particular concern. Again, from the HIV-infected literature, we know that 3 to 4% of bone mineral density can be lost in the first year of HIV treatment with tenofovir disoproxil fumarate containing HIV regimens. We also have learned that calcium and vitamin D supplementation can mitigate that bone mineral density loss by 50%. So it was not a surprise to see in these early PrEP studies about 1% loss of bone mineral density over the first year. We do not yet know if calcium and vitamin D can mitigate those bone mineral density losses, but happily, so far, the 1% loss of bone mineral density has not been seen to be associated with an increased fracture risk. However, most at-risk populations tend to be young, and young people are still accruing bone mineral density. So a recent study presented at the Complications Conference in Barcelona in youth age 18 to 22, these are MSM and transgender women, found a loss of about 1.5% of bone mineral density. But the problem is in individuals who should have been gaining bone mineral density. So the delta, the difference from what they should have been seeing compared to what they were seeing is actually probably double. And so that is a concern about the use, particularly in youth who will still be gaining bone mineral density. How do we support daily adherence? Well, RAPHAEL, a behavioral scientist from the University of Michigan in the US, has developed and published on a strategy called Next Step Counseling. She has developed this. It hasn't been tested in randomized settings, but we have the most experience with it. It's a 7-step, strengths-based intervention that can be deployed by clinicians to help navigate the barriers to adherence to a daily medication. That's probably the best thing that we have today. The CDC in the United States issued some very general guidance to clinicians that had 3 steps that basically said, you have to start by taking a sexual history. If you don't talk to your patients about sex, you cannot have a conversation about what they're doing to protect themselves against HIV acquisition, and this is critical. We have a number of studies ongoing that are looking at text messaging to support daily adherence. There are smart devices that will remind you if you did not take your medication. This smart pill bottle here is being developed by a company called AdhereTech, and it will light up if you don't take your medication. And then if you still don't take your medication, it will chime. And then if you still don't take your medication, it will text message you. And then if you still don't take your medication, it will email your doctor. No, thank you. Let me talk for a moment about IPERGAY. IPERGAY is a very exciting study. We first heard about it a year ago, and it addresses this question of, can you take PrEP just around sex? Can you do intermittent dosing, pericoital dosing? And the strategy of IPERGAY was a brilliant one, and was one that Jean-Michel Molina developed in response to questions that his patients were asking him. If I know this weekend I'm going to go out and have sexual relations, can I take a double dose of the tenofovir emtricitabine within 1 day before that, a second single dose 24 hours later, and then a third single dose 24 hours after that, and then stop? Randomized double-blind trial. And it was stopped early because it was so highly effective, 86% effective in the active arm compared to the placebo arm. Number needed to treat to prevent one HIV infection, 18. Very exciting result. Many patients came in saying, I want to do that. Of course, the problem is there were very, very few people, very few patients in the IPERGAY study who had a single isolated sexual experience. Many of them were much more sexually active. In fact, the median number of doses taken in a month by the participants in IPERGAY was 15. That is on average 4 pills a week. Mathematical modeling suggests 96% protection with 4 doses a week in the IPREX study. So what this says to me is that there is some forgiveness against rectal exposures, but to try and guess when someone is going to be sexually active when they are very sexually active is only trying to fix the system, and it might not work. And therefore, I do not believe that this is ready for prime time yet for deployment as part of recommendations, my personal opinion. Even more so, there have been 2 sets of studies, including the IPERGAY study itself, that suggested that people have trouble adhering to intermittent dosing regimens. In addition, Dr. Molina has presented some data that suggests that that single double dose of the tenofovir emtricitabine and then following rectal biopsies, the in vitro does not provide protection in those biopsy specimens. So you do not get probably adequate protection from that single double dose right up front. And people who take it thinking that they are protected may be incorrect, and therefore it may not be appropriate to recommend it as part of guidelines. HPTN 067 was a study that looked at 3 different regimens of dosing, daily dosing, twice weekly dosing with an additional dose after sex, and just event-driven dosing around sex. And it was done in women in South Africa and in men who have sex with other men in Thailand and in New York. And the bottom line of the 3 different pieces of the study was that people had drug in their system around their sexual acts most frequently when it was taken every day or attempted to be taken every day. It fit into people's lives better to take the medication on a daily basis rather than to try and be strategic about when to take it. In the US, we have a number of demonstration projects that are trying to help people maintain this daily adherence. My group is studying 300 gay men and transgender women using real-time drug levels to help counsel them about whether or not there are protective levels of the medication in their system. And if there are not, what they can do to help themselves stay protected. We are finding very high levels of protective drug in the samples of these patients, but we are also finding that people often disappear and do not come back to the clinic. So although overall we have 80% of people who are on study drug and showing up to the clinic having protective levels, only about 60% are actually coming back to have those levels tested. The open label extension to the IPREX study again suggested that people who had drug levels suggestive of 4 doses a week or more did not get infected. I worry about that being a guideline because we don't know how those missed doses surround sex would impact the efficacy. I think it again reminds us that there is some forgiveness, but that really the goal should be to achieve daily dosing. Again, Al Liu's demo project in 3 cities in the US found high levels of achieving 4 pills or more and very low rates of HIV infection occurring only in those who had no evidence of drug in their system. The Kaiser Permanente clinical cohort reported on their experience in highly educated, insured patients in Northern California. And they have shown no HIV infections in a cohort of over 600 clinical patients who are being administered PrEP, but high rates of sexually transmitted infections. In order to maximize the impact, you have to target it best at people who are at highest risk. This is particularly important knowing your population and is important in the VOICE results as opposed to the IPREX results. In IPREX, people with the highest risk had the best adherence. In the VOICE study, people with the highest risk had the least adherence. So getting the medication to the right risk groups can make all the difference in the effectiveness of the intervention. In the US, we are nowhere near where we need to be if we're going to have population-level impact in terms of deploying PrEP. We're about 1/3 of the way there in our most advanced cities like San Francisco. Gilead has presented some data that there seems to be an uptick in the US in prescriptions for PrEP, and we seem to be in an exponential phase, which is very exciting, but we don't know if we're reaching the most at-risk and vulnerable populations. The community understanding of PrEP in the US is very low. We asked patients what they knew about it, very few knew about it. And providers had enormous barriers to implementation. Primary care providers said, we are too busy to have a conversation about sexual health. HIV providers said, we cannot take care of HIV uninfected patients, even though we have the most expertise with the use of antiretroviral medication. We call this the purview paradox, because everyone says, I don't want to be the one prescribing PrEP. Finding a PrEP provider in the US is very difficult, and people are resorting to crowdsourcing, Facebook pages where people share experiences of what doctors, what providers are willing to provide PrEP and how to navigate the expensive payments. It's become very complicated to understand how to finance it. There are community-based organizations that are helping lead this, and the guidelines from the WHO and others are very helpful. And New York City has taken a very interesting approach, very much like a pharmaceutical company detailing providers. They have trained academicians to go into practices and talk to practices and providers about how to deploy PrEP. In the interest of leaving Dr. Pozniak some time, I'm going to skip over a couple of slides here, and I'll be happy to answer questions at the end. But I think we can say that the future is very exciting with other opportunities for PrEP. Maraviroc, an HIV prevention study in phase 2, is just being completed, and we will hear safety results at CROI this coming spring. TAF, tenofovir alafenamide, less bone toxicity, less renal toxicity for treatment, but will it work for prevention? I think Gilead is also planning to present some preliminary macaque model and explant data to suggest its efficacy could be exciting. Injectable therapies are in phase 2 study that could be administered as infrequently as every month or 2 months that could remove the need for daily dosing. Immunotherapies, monoclonal antibodies, and implantable devices like those used for contraception are all in early phases of study. I'm sure we'll be hearing more about intermittent PrEP and more about how to target PrEP to the most at-risk populations, including minority populations with highest incidence and youth, as well as combining interventions. I will stop there, and I thank you very much for your attention.